Hi everyone, and thank you once again to Joao and the organising committee for this opportunity to speak to you today about the specific question of cholesteatoma recurrence in adults. And I wanted to answer the question for you with the current evidence as to whether a particular surgical reconstructive technique, that is attic reconstruction, compared to mastoid obliteration, might be the way to go to try and reduce the recurrence or the re-retraction of cholesteatoma in adult patients. So when we're talking about recurrence in adults, what are the factors that may be important? Well, some of these are fairly self-evident, but let's run through them. The first is the actual phenotype of the cholesteatoma, and that is whether the cholesteatoma is isolated and well encapsulated and uninflamed, and it dissects out in the primary operation very easily, compared to disease that's fairly inflammatory, infiltrative, mixed in with granulation, can be adhesive to the surrounding bony structures, and this may increase the risk of recurrence. There are regional factors that are actually quite difficult to find in the literature, the impact of these, but intuitively, when we have disease such as eosinophilic otitis media that is involving the ear as well as the continuous airway and the chest, this can be of relevance, the function of the eustachian tube as well as the mucosa in the middle ear. These can all play factors as to whether recurrence can occur, but this is difficult information to find in the literature. Specifically, I wanted to answer for you today whether certain surgical techniques could play a part in preventing recurrence, and whether specifically attic reconstruction compared to mastoid may be a better technique. So for this, I really wanted to avoid talking about mesotympanic disease and I wanted to avoid talking about congenital cholesteatoma and focus the question for you on attic disease, primary attic disease, and how do we do the reconstruction after the initial extirpation to try and reduce the rates of recurrence or reformation of cholesteatoma in these cavities. And to do this, I looked at the last 10 years of data, looking at high quality data. So data which had ideally 5 years of follow-up if possible, with the staging system and the presentation being appropriate to the current best system classification. And we prefer outcome data to be presented with Kaplan-Meier presentations and logistic regression. So looking for papers that presented like this, and ideally we have matched cohorts or case control studies, or ideally randomized control trials, otherwise high quality meta-analysis or systematic reviews to try and give you the best answer to the question. So when we're talking about attic reconstruction, the way I like to subdivide it is, are we using autologous materials or are we using artificial materials? And in attic reconstruction, the classic methods involve autologous materials, most classically with cartilage, but there's several papers published using bone pate, chips or cortical bone, and then artificial materials which we aggregate into one group. If we look at autologous cartilage, this is the method that's most commonly done. And here I've drawn a cartoon for you showing in a left ear how we reconstruct a small attic resection of a cholesteatoma. And you can note that we try and perfectly size and sculpt the cartilage to fit the space of the scutectomy. And the scutoplasty tries to match this with an overlying skirt of perichondrium. And so this is ideally slotted and positioned into place so that it doesn't move, and locked not just in the attic canal wall, but also on top of ideally a primary ossicular reconstruction. So if I show you a video here, we're sizing and measuring the attic defect, and once again the cartoon demonstrating how we'll fill that gap. And then I harvest some tragal perichondrium. So you can see, as I mentioned to you before, we try and slot it neatly onto the cartilage of the ossicular reconstruction. So we have the concave tragal cartilage, and we turn this down and we remove the thick perichondrium and leave the thin anterior perichondrium as a perichondrial skirt. Now this can be done in several ways, and you can separate the perichondrium if required. A primary Kerr's prosthesis is used for the reconstruction, and here I'm fashioning the cartilaginous cap, and I'll try and place that so that's locked under the scutum. You'll see when you see the video coming up that when we're placing the final bit of cartilage and perichondrium, you can see how the cartilage is locked nicely. So this is a well coupled prosthesis, and then this second cartilage piece, which is fashioned ideally and matched with We use some foil to try and identify the size of the material, but you can also use bone wax and other techniques. Then this is sized and locked into place on top of the ossicular reconstruction. Some of the best data we have for the use of cartilage comes from Professor Prasuti and Marchioni in Modena and Verona at this time. And this was an interesting study where they were looking specifically at trying to reduce recurrent disease. So they had patients, a 55 patient group that was done endoscopically, and then a historically controlled cohort of canal wall up surgeries with the same volume of primary acquired attic cholesteatoma being studied. And they had a mean follow-up of 5 years and showed for recurrence rates that when they did the case endoscopically and with a primary reconstruction to try and recreate ventilation, that they tended to get less recurrence. And this tends to follow the theory that Professor Marchioni and Prasuti initially published on the selective dysventilation, where there's primary isthmus obstruction for cholesteatoma formation. And so if we try and recreate the isthmus with our reconstruction, then this may reduce the recurrence from 9% compared to 22% with the canal wall up group. So in summary for that paper, we potentially are doing like what we do for functional sinus surgery, preserving the mucosa, recreating the ventilation in there with intact chain surgery or primary ossicular reconstruction, and performing the case endoscopically so we can be very careful about how we deal with the mucosa. This may trend towards reducing the recurrence rates. The only slight argument against this is that if we've got cases where the mucosa was preserved in the mucosal preservation score, that tends to imply that this is phenotypically less aggressive disease and potentially less staged disease when they were trying to match the two groups. But nonetheless, this is an important point, which I think I'll come back to at the end of the talk to try and highlight how we might manage specifically attic disease with the primary resection. If we're looking at other autologous materials, bone pate plays a large part in the literature, and here's some of the best data I could find. A highly powered study. It's fairly old now, 18 years old, but they used bone pate and fibrin glue in this study and showed the bone resorption rate. So these were all followed up with a minimum of 3 years, up to 5 years follow-up. And bone resorption rates were at 6%, with 4% being partial, 2% being total. And the recurrent cholesteatoma rate was quite low at 5%, with self-cleaning attic retractions at 4%. So matching the best figures that we can find, but again, fairly variable in terms of the follow-up, but between 3 to 5 years follow-up in these patients. So I think when we're looking at attic reconstruction, particularly if we've got large attic defects, bone pate may play a part in how we think about reconstruction. Cortical bone has also been used here, an interesting study looking at a different mastoid phenotypes. They looked at mastoids that were contracted, low tegmen, anterior sigmoid, and took out the canal wall, removed the disease, and then put the canal wall back essentially, and showed minimal attic reconstruction, attic re-retraction at 2 years of 1 out of 35 patients. These were all patients that had a second look procedure to check if there was a re-retraction or a recurrence. And interestingly, look at this mastoid phenotype of a contracted mastoid. A lot of their re-retraction occurred in the mesotympanum, which tends to tell you that perhaps it was the mastoid phenotype that showed where the re-retraction was going to occur, because in fact there's not a lot of mastoid space for the retraction to occur within. And then in terms of artificial materials, here's a study, small numbers with a short follow-up of only 2 years using bone cement along with cortical bone, showing that there was an 8% recurrence here. So again, the use of bone may be useful. I wanted to include this study because it was quite tightly controlled to our study or talk question, that is attic reconstruction. And it's from Australia, Professor Bruce Black in Queensland. And he looked at 35 of his second look cholesteatoma procedures. And he did this interesting underlay of 0.12 millimeter titanium. And what he did was he folded in 2 ways, and he's described it meticulously in his paper, how he locks into place this titanium lock and then uses that as a scaffold to allow him to reconstruct on top of with cartilage. And he showed in 12-month follow-up, so again, short follow-up times, only one recurrence in this particular scenario. And I think this highlights to us that when we're looking at attic reconstruction specifically, we need to look at precise placement of the cartilage or the bone, and ideally trying to lock these cartilage pieces into place. And in fact, I might even suggest that we use underwater irrigation to test whether they move or not, to see if they stay in place, and then potentially use bone pate on top of that to try and reduce the displacement of this attic reconstruction cartilage to prevent recollapse and recurrence of cholesteatoma. So this study was important in highlighting how important it is as a scaffolding. Now, how could obliteration play a part in this story? Well, mastoid obliteration is not a new technique. It's been published for over 30 years. And the potential method with which it might work is that, of course, if you obliterate the mastoid, and if the material actually survives and stays in the mastoid, then there's less space for the cholesteatoma to retract within. So this makes sense. It's logical. And potentially, if we're looking at the compromised eustachian tube function theory of cholesteatoma formation, then if we reduce the mucosal surface that's required for the compromised eustachian tube to ventilate down to just the mesotympanic surface of the middle ear, then maybe this reduces the burden on a compromised eustachian tube, and in that way it might reduce the risk of recurrence. Once again, when we're looking at obliteration, I like to subdivide it into, broadly speaking, autologous or artificial materials, and there's quite a lot published on obliteration, and I'll try and once again fine-tune our discussion to illustrative examples, but then also examples that might help guide us into decision-making for what to do for our own surgery. So if we look at autologous materials, we have the classic ones, which include fat, cartilage, and bone in various methods, but classically in bone pate. And then we have soft tissue transposition flaps, which can be placed not as free grafts, but as transposition flaps, which might help with angiogenesis to the free grafts that we've put into the mastoid. Secondarily, there's quite a lot published in terms of artificial materials, and these are most classically used when there's not enough of the autologous material available. And we have hydroxyapatite, calcium phosphate, different cements, and demineralized bone, but most importantly, bioactive glass, as well as hydroxyapatite glass crystals, which seem to have, with the longest follow-up, been most reliable in creating stable cavities where there's no resorption of the obliterated material. If we're looking at the fate of autologous free grafts, we actually have some data from Fred Linthicum's group from the House Ear Clinic, and he studied autopsy specimens of beyond 10 years of patients. And the summary of the paper was that fat and bone as free grafts, so these are not transposed grafts, these are free grafts, fat and bone tend to survive well. And they actually osteoinduct. And by that I mean when you put the grafts in, it creates angiogenesis and new bone formation within the actual graft itself to recreate the bone trabecularly within the obliterated cavity. Free muscle and soft tissue, interestingly, doesn't tend to survive as well as free grafts. We know certain artificial materials don't survive well at all, and hydroxyapatite ceramic has poor results. Here's some data published out of Germany and as well as Switzerland, demonstrating that they had a high revision rate in their cohort of over 50 patients and no significant change in quality of life. So they've moved away from this specific material. So certain artificial materials we know we shouldn't use in obliteration. Here, ceranosem granules are contraindicated. This work, published in 2017, demonstrated resorption. You can see in this axial CT scan of the right ear, boning resorption over the sigmoid sinus. So they've actually contraindicated this particular material for use in obliteration. So certain artificial materials are really not good at all to use. The ones that tend to give us good, stable results with no resorption and tend to have stable cavities beyond 5 years tend to involve crystals. And we have hydroxyapatite crystals that tend to have better results. And along with this, we tend to have bioactive glass crystals that have been published in the literature. And here's a systematic review with one of our friends Arun Iyer, as one of the authors, looking at synthetic materials in mastoid obliteration, showing that bioactive glass crystals and hydroxyapatite tend to have the best results. These tend to be the most bacteriostatic and osteoinductive. Like I mentioned to you, free fat and bone can be osteoinductive, and these glass materials, particularly bioactive glass, can be quite osteoinductive and tend to recreate the trabeculae within the mastoid cavity. Now, soft tissue transposition flaps in mastoid obliteration can be important. So remember I told you soft tissue that was a free graft didn't survive well, but soft tissue transpositions are very different. And here you can see an image of me elevating a middle temporal artery flap here based on the middle temporal artery off the deep temporal artery. And these can be transposed down, typically covering the free bone or fat or the crystals to try and potentially provide more angiogenesis in this area. So the classic two grafts that are published, one comes from the middle temporal artery, but you can of course use temporoparietal fascia, which is lateral to the temporalis muscle, and then branches of the occipital artery supplying the periosteum extending off the mastoid tip is also classically described. And you can see with these pedicled transposed soft tissue flaps that these may provide angiogenic factors, and these I tend to use quite liberally when I'm reconstructing in mastoid obliteration, and they probably help with providing at least angiogenesis to the lateral bulk of the mastoid cavity. I think it's an open question where to place these flaps, whether we put them into the central part of the obliteration and put some bone in, then the flap, and then some bone on top of that, or whether we put it laterally or deep in the cavity. I think that's an open question that hasn't really been answered properly in the current available literature. A couple of tips when we're looking at canal wall up obliteration, and when we're thinking about obliteration, in my mind, it's actually like a reverse cartilage attic reconstruction and then putting bone behind it. And what I mean by that is that when we're doing attic reconstruction primarily, we tend to try and precisely fashion the attic cartilage or bone pate into the actual space that we've created with our primary resection. But this is what I like to do when I'm doing an obliteration, and that is create a cartilage lock. So you can see in this left ear, I've used several pieces to lock into the attic and then into the posterior tympanotomy, and I try and push it into place and lock it. And here underwater with copious irrigation, you can see I'm checking that the actual cartilage lock is not moving at all, and you can see how there's some periosteum attached to the cartilage here, but there's no movement of the cartilage at all. And in my 5 years of experience with obliteration, I think this method tends to work a lot better to try and prevent any recurrent disease in the anterior epitympanum, which is where I've had recurrent disease in these instances. So if you're doing obliteration, consider cartilage locking or firmly placing your reconstructed canal wall down cavity, reformed posterior canal wall so that it doesn't move. And the other thing that I found very useful is timing the use of the fibrin glue. So of course, those of you that use fibrin glue, we use this. So I particularly harvest the bone, autologous bone, and I keep it in ciprofloxacin. You can keep it in several antibiotics that are published. Rifampicin is the other commonly used one. And then when we're ready, we tend to mix this bone with fibrillin glue, and this tends to provide a nice solid foundation to fill the mastoid cavity. And then I transpose a flap on top of that to try and help with vascularization, particularly in canal wall down surgery. I don't find the transposition of the flap that important in canal wall up surgery. So what sort of data do we have for outcomes for obliteration? And here's work from a Dutch group looking at a large systematic review of single-stage mastoid obliteration with primary attic mastoid disease, looking at recurrence and residual disease in these patients. And you can see they've got 1,534 patients in this systematic review. And if we're looking specifically at recurrence rates in canal wall up with various methods of reconstruction, including all different techniques, autologous as well as artificial, 4.7% recurrence. Now, the problem with this study, of course, and with all systematic reviews is that if you have varying results coming in, the systematic review gives you varying results. So the time point for measuring where the recurrence was varied from 1 year up to 10 years. So not clean data for us to get good answers from, but nonetheless useful information. And in canal wall down surgery, we have low recurrence rates once again as well, 5.8%, but again suffering with that same problem of varying time points when we're looking at this data. What about if we wanted to get cleaner data than this? Well, this is from Van der Toom's group once again. Single series from one group looking at 337 adults with a minimum follow-up of 5 years presented with Kaplan-Meier regression analysis. And we can see if we're looking at recurrence and if we're matching the obliteration groups to the canal wall up to the canal wall down, and this was looking at recurrence in the clinic. And I must highlight to you that their clinic comeback rates were at 80%. So they were able to follow up patients beyond 80% of their patients beyond 5 years, which is, I personally would consider a very high clinic reinspection rate. They found a 4.4% risk of recurrence compared to 21% in canal wall up, and that's quite fitting with the current literature that's of non-obliteration, and canal wall down 8.5% in this particular series. But here's the clincher slide. And here is an outcome heat map of recidivistic location. So this is a combination of recurrent and residual disease. And look at where the bulk of recurrence tends to occur and residual disease in bony obliteration. It occurs in the tympanum. Now, we know that we've got several randomized research trials in adults that demonstrate that the use of the endoscope in the middle ear has advantages compared to the microscope and lower residual rates compared to the microscope when we're using the endoscope. And I have to highlight to you that Van der Toom's group are not endoscopic surgeons. So they were getting these low recidivistic rates without the endoscope, but their failures with the obliteration tended to occur in the middle ear. So imagine if we used obliteration along with the endoscope, we might be able to reduce those rates even lower. And then the canal wall up recidivism occurred in the areas where you'd imagine, and the canal wall down, interestingly, largely in the mastoid itself. There are disadvantages to obliteration, and one of them is the operative times are longer. And in fact, wound infections tend to occur a lot more than in endoscopic cases or in other cases. And it tends to be higher in the use, as expected, of artificial material compared to autologous material. So here, another study from Australia looking at the materials used for obliteration and complications. They found that artificial material complication rates varied from 12 to 24%, with autologous materials lower at 4 to 15%, and this reached statistical significance. The other issue is that if we don't obliterate properly, we can still get recurrence. And here's some of my early work, and you can see here I'm doing an endoscopic repair, and I actually used artificial material when I repaired this particular case of a recurrent cholesteatoma that occurred after the bone that I'd placed anteriorly resorbed considerably. And I think this would have been avoided if I did that technique of cartilage lock that I was talking to you about before. So then if we're putting together all of this information of attic reconstruction compared to the data for obliteration, how do we manage our attic cholesteatoma? Well, two things come to mind. One is that we know most likely with recurrent disease in the children, and we have some nice data from Professor James published just this year with a very nice analysis of over 400 cases of pediatric cholesteatoma that basically good ears do well and bad ears do badly. And he demonstrated that the worse the initial stage of disease, the higher the risk of recurrence. And in other words, if you had stage 1 disease, the risk of recurrence is around 11%, stage 2, 22%, stage 3, 33% recurrence rates. And as you go longer in examining these patients, at 10 years, you have a 29% chance of recurrence, and these tend to occur in higher stage disease. And this likely is a different phenotype of cholesteatoma, we know that, but some of this probably translates with adults. In other words, bad disease probably does badly in adults too. And then on the right side of the slide, you can see that we know in residual disease, when we're removing disease, that with the use of the endoscope, we have 4 randomized trials published in the last 3 years, demonstrating that the endoscope is at least equivalent in terms of residual removal of disease in the middle ear. And it tends to be superior because we tend to have quicker operating times, better visibility, and less pain. So the preferred method to remove disease in the mesotympanum and limited attic disease is with the endoscope. So if we put these two bits of information together, then looking at the evidence, we probably should look at our attic cholesteatomas in this way. We look firstly at what the stage of the disease is, try and start to classify your cases with this STAM system and the ENO or JOS system, and then look at the cholesteatoma phenotype. You know that disease which is limited, localized, not very inflamed, coming out at a nice well-dissected sac is likely to have lower residual and recurrence rates. So maybe we look at primary attic reconstruction there. And then look at the mastoid phenotype. If you've got a small contracted mastoid, that's going to affect whether you do a mastoidectomy or not, inside out mastoidectomy, inside out endoscopic case, and whether you reconstruct. These three things should play in your mind when you're looking at what you should do in terms of attic reconstruction. So if you have small volume, well circumscribed disease with stage 1 disease, then I think this makes sense following Professor Prasuti and Marchioni's case control study to do an attic reconstruction and primary acicular chain reconstruction. And here we look at precisely placing the cartilage in and locking it into place. And if there's any spaces, maybe using a little bit of bone pate or curetted bone to fill those areas before placing the perichondrium on might be a good idea, looking at our bone pate results. And if when you're dissecting, you've got very difficult disease, if you've got a mastoid phenotype, first of all, that's contracted, or if you've got inflammatory disease, like you can see in the middle of the screen there, and it's adhesive and not easily dissected endoscopically, or aggressive stage 2 to 4 disease, then I think most endoscopic surgeons are now saying do a limited atticotomy or minimal atticotomy there and move fairly quickly to the microscope and do the mastoidectomy and use the endoscope from behind if you want, and try and preserve that scutum there. And any reconstruction you do, try and use the cartilage lock here and bone pate. So in other words, with aggressive disease, minimal atticotomy, and try and come from behind to try and prevent any residual recurrence. And then you decide whether you want to do obliteration or not. But I personally have moved to an obliteration in these patients. So I hope that wasn't too arduous for you and you took a couple of messages away from that talk. It really was quite a useful tour through the data regarding attic reconstruction versus mastoid obliteration. And once again, thank you for the opportunity to speak and hope you enjoy the rest of the conference. Thanks everyone. Hope to see you soon.